is Steve Krouse, and I'll be presenting today on scaphoid fractures. The majority, 70% of all carpal fractures involve the scaphoid bone due to its function as a bony block, limiting wrist extension, which makes sense because its mechanism of injury is a wrist hyperextension. The scaphoid receives the majority of its blood supply from the distal end of the radial artery, so in a lot of cases the fracture will compromise the nutrition, leading to a high incidence of non-union, which is basically that the fracture doesn't heal, never heals all the way, or malunion, meaning it heals in the wrong position. It's most prevalent in the 15 to 30-year-old population, mainly because they're most active, but also the very young and old are more likely to fracture the head of the radius instead of the scaphoid. The incidence rates are 38 out of 100,000 for males and 8 out of 100,000 in females. And 80% of scaphoid fractures occur through the wrist. And unresolved fractures can lead to Krouse disease, which is basically osteoporosis of the scaphoid due to the nutrition and loss of blood supply. There's different classifications for scaphoid fractures, and it depends on location, instability, and displacement of the fracture. So type A for scaphoid fractures would be stable acute fractures. And there's also subtypes. So for instance, A1 would be fracture of the tubercle, and A2 would be incomplete fracture through the waist. And then type B would be unstable acute fractures, type C delayed union fractures, and then also type D established non-union fractures. The mechanism of injury, like I mentioned before, is caused by axial loading of a hyperextended radial deviated wrist, or a forceful compression of the scaphoid, which will happen when you hyperextend. Also, loading at lesser degrees of extension causes distal radial fracture, whereas dorsiflexion beyond 90 degrees can result in carpal injuries, specifically the scaphoid fractures, especially if radial deviation is involved. Some of the signs and symptoms are swelling in your anatomical snuff box, and also tenderness over the scaphoid tubercle will also be a sign. Patients won't be able to, or will have pain upon longitudinal compression of the thumb, it's pressing down the thumb, and pain with active and resistive wrist extension. They'll also have pain if you do overpressure for passive flexion and radial deviation, and they'll also tend to have decreased grip strength. And also there will be a positive scaphoid compression test, which basically is compressing the first digit, or the first carpal bone. Treatment for these injuries, most undisplaced fractures can be treated with a short arm cast with union rates of 88 to 95%. And typically you're going to be in a cast for 2 to 6 weeks with those. And once a cast has been removed, initial treatment focuses on restoration of range of motion and strengthening. If there's any amount of displacement though, operative treatment is warranted. And with that they do open reduction with internal fixation using a Herbert screw. And also, athletes a lot of times will just choose to undergo surgery right away because since there's such a high incidence of non-union and malunion fractures, if they take the conservative approach and wait, a lot of times they'll end up having to have surgery anyways. So a lot of athletes will choose just to have the surgery right away so they can come back quicker and just fix it right away. On-site evaluation and management, you're going to want to first, I would do your primary survey, make sure there's no other injuries involved. And also make sure you're checking for neurologic symptoms, especially capillary refill. Secondary survey, you want to palpate the anatomical snuff box and distal tuberosity of the scaphoid. Test all of range of motions, which, like I mentioned earlier, may not be possible depending on their pain level. And manual muscle test all muscles responsible for extension, flexion, and radial deviation. And also, a lot of times scaphoid fractures have had trouble showing up on x-rays, so it's good to get a bone scan or an MRI as well for the scaphoid fracture. Are there any questions?